Hi, my name is Scott Kopetz, Associate Professor of GI Medical Oncology at MD Anderson. I'm joined here with my colleague, Dr. Ilsen, Professor of Medicine and Medical Oncology at Memorial Sloan Kettering Cancer Center. We're here to discuss key insights from the great debates in GI malignancies. And Dr. Ilsen, welcome, and thank you for organizing a very insightful and I think lively meeting. At the meeting, we've heard many updates on the areas of neuroendocrine. We'll touch on areas of new and novel therapies in neuroendocrine. Gastric cancer, some advances there that have real clinical implications in terms of how we manage patients in the adjuvant setting. Of course, novel therapies, immunotherapies are making a role in GI malignancies, including gastric cancer, and some advances in pancreatic cancer, as well as potential promise of novel therapies. So a lot of great information covered at the meeting, and I think a lot of opportunities to really change our practice now and the future as a result. So, Dr. Ilsen, thank you. Wanted to start perhaps with a tumor type that has seen some more advances recently in the realm of neuroendocrine tumors. Some novel therapies coming, and I think certainly areas for hope. What were your takeaway messages from this meeting?
Yeah, well, I think we had Dr. Strasberg, who was the first author on the radio-labeled somatostatin analog study, recently published in the New England Journal of Medicine, so indicating that in refractory neuroendocrine tumors that this agent, certainly in refractory carcinoid tumors, radio-labeled somatostatin analog led to pretty significant improvements in progression-free survival and actual measurable response in these tumors where we see almost virtually no responses to systemic therapies, and a very strong trend to show survival benefits. So I think the advent of radio-labeled somatostatin analog therapy is going to be an advance in this disease, and this is patients that have failed other therapies. And this comes on the tail of approval in the last few years of other targeted agents, including VEGF-targeted therapies like sunitinib, mTOR-targeted therapies like everolimus, which now have a role in pancreatic neuroendocrine tumors, and also for carcinoid tumors, evidence of benefit for everolimus. And also recently, approval for a supportive care medication, because as we know, diarrhea is really a significant symptomatic problem of carcinoid syndrome, and now approval of a new agent that will alleviate diarrheal symptoms compared to supportive care beyond the use of somatostatin analogs. We also had a lively debate about the role of surgical resection in neuroendocrine tumors, and clearly in appropriately selected patients, certainly all the treatment guidelines advocate in the appropriate patient a potential role for either complete surgical resection of limited disease or surgical debulking later on in the history. But I think this is certainly an area of excitement, new drug development, new agents, both in the supportive arena and also in treating advanced metastatic disease.
Wonderful, and it was as you highlighted, a good debate here on the role of surgery and the recognition, as was highlighted, that there's good surgical series suggesting this. And I think one of the questions that does come up is debulking. You touched on that a bit, and that was a good point of the debate and discussion. What is your practice in this area?
Yeah, I think it's really for selected patients that have symptomatic, really hormonally functional tumors that are candidates for potentially surgical debulking to really relieve symptoms. This is certainly not patients that we're going to cure, but given the often indolent nature of these cancers over many years, that in the appropriate patient, surgical management, even in the later stage setting, may be appropriate in very selected patients.
Wonderful. I think one of the things we also heard that potentially updates on how we should manage our patients is in the realm of gastric cancer. And I think the data being presented and discussed about adjuvant therapy and what's the optimal strategy there. What was your message for practice change in that area?
Well, we certainly had a debate with a radiation therapist about the role of radiation in adjuvant therapy, and I think it's clearly emerged that there are 3 appropriate strategies for adjuvant management in gastric cancer. And a lot of it depends on the adequacy of the surgery that's performed. So in the US, I mean, the first really positive trial was after gastric resection was postoperative 5-FU and radiation, which was really the first adjuvant trial after many decades of studies to show a benefit. But the critique of that study was the quality of the surgery was quite poor, and is radiation really needed if good surgery is performed? Then the sort of next wave came from Europe and Asia, really showing that chemotherapy alone as an adjuvant strategy conveyed a survival benefit. Perioperative chemotherapy from the UK MAGIC trial became adopted as a US and European standard. Patients getting perioperative chemotherapy with no radiation showing a survival benefit. Then Asian studies, I mean, that's less of a practice in the US, but in Asia, upfront surgery is usually offered for patients, and for a stage 2 or 3 disease to give adjuvant chemotherapy for 6 months to a year is now an accepted standard, and certainly adjuvant capecitabine oxaliplatin in patients that go upfront D2 resection is an accepted standard of care. So the debate at this meeting was, is there still a role for radiation in that setting? And the data that I really highlighted, which I think are relevant for Western practitioners, is the CRITICS trial, which was presented at the ASCO meeting last year, which, because there had been data from a Korean study suggesting that in the setting of a D2 resection, patients get upfront D2 resection, that chemotherapy alone resulted in the same survival benefit as chemotherapy plus radiation. That if good surgery was done, radiation therapy did not play a clear role, which harkens back to the original criticisms of the US trial, which showed a benefit for postoperative radiation, but in patients that really underwent suboptimal surgery. So the CRITICS trial, contemporary study, patients well-staged, endoscopic ultrasound, often laparoscopic staging, and patients all received perioperative chemotherapy. And then post-surgery, there was a randomization to complete the perioperative chemotherapy or to get chemotherapy plus radiation. And this was a 750-patient trial, and good flow of patients through the study. 85% completed the preoperative chemotherapy, 95% went to surgery, and a mixture of D1 and D2 resections, about 40-50% split. But certainly a minimum D1 resection, and almost half of patients also had D2 resections, and there was no survival benefit for adding radiation. So again, it really reinforces that systemic chemotherapy does play a role in the setting of gastrectomy, whether it's given perioperatively or in the adjuvant setting postoperatively. But if a good surgical quality is maintained, there's not a clear role for adding adjuvant radiation. And I think that's a practice-changing study, because there's still some that advocate that we need to use this US data from 15 years ago, that we need to give these patients radiation. And this study, I mean, we're still waiting for subset analysis, but the progression-free and overall survival curves were indistinguishable, showing that there's really no benefit for radiation in the setting of perioperative chemotherapy. And when we factor in that these are patients in their 60s and 70s, we really don't want to expose them to the morbidity and toxicity of postoperative radiation if there's no demonstrable survival benefit. So I think, to me, that really is a practice-advancing study, and I think I won the debate about radiation not being given.
No, and it's certainly, as you mentioned, something that really understanding the data in the current contemporary context is certainly important, and I think a good point that was brought up in that discussion. And certainly when we see the advances that we're making in who to treat better and better selection of these therapies, we also recognize that we're making headway on the other realm and bringing in new therapies, and that certainly in the realm of immunotherapy in gastric cancer, some promise there. What were the highlights for you for the updates in immunotherapies?
Yeah, I think certainly at this meeting we focused more on the immunotherapy data for colorectal cancer. You know, the MSI high data, quite provocative that these are active agents in MSI high mutation burden cancers. In non-colorectal cancers, there's a signal of activity across the board for anti-PD-1, anti-PD-L1 therapy, modest signal of activity, response rates of 10 to 20%. And recently, phase 3 data from Asia in chemotherapy refractory gastric cancer comparing best supportive care versus nivolumab, which is an anti-PD-1 drug, showing a signal of response in about 10% of patients and about a 27% survival. So a survival improvement at 1 year compared to 10% alone for best supportive care. So there is clearly a signal of activity for immunotherapy in gastric cancer, and whether or not there's a biomarker that can enrich that benefit, do patients that are PD-L1 positive do better? There is a suggestion of that. Combination immunotherapy strategies are now being looked at even in the first-line setting, CTLA-4 therapy plus anti-PD-1 therapy, looking at nivolumab, ipilimumab combination upfront versus chemotherapy. And then a number of studies that are going to report out comparing chemotherapy plus immunotherapy versus immunotherapy alone versus chemotherapy alone, and additional studies exploring the role of immunotherapy versus late-line chemotherapy drugs. So a lot of data coming in the pipeline, but now a positive trial in refractory disease suggesting small evidence of anti-tumor response and a survival benefit at a year for anti-PD-1 therapy versus best supportive care.
It's wonderful. And certainly I think you highlight something that we saw through the meeting, which is some smattering of activity with immunotherapy across many different tumor types in the GI space, with one exception, and that was pancreatic cancer.
Yeah, pancreatic cancer, I think, unless you have an MSI high tumor, which is going to be single-digit percentage, immunotherapy does seem to be not active in pancreatic adenocarcinoma, quite disappointing.
Yeah, and certainly combinations being explored. But there at the meeting also highlighted some advances in pancreatic cancer and other novel therapies.
Yeah, I think genomic profiling, a lot of the abnormalities found in pancreatic adenocarcinoma are not targetable, like RAS mutation certainly, and some tumor suppressor genes that are lost. But BRCA does seem to be affected in about 5 to 10% of patients, and not always in the familial setting. And we know that BRCA mutant tumors may have higher platinum response and may also be candidates for PARP inhibitors. And actually, we have PARP agents now approved in BRCA-related ovarian cancer. So a lot of interest in studying PARP inhibitors in the BRCA-affected pancreatic cancers, and some promising early phase data and now in randomized trials. But again, a very small subset of patients, but we may see some headway with that class of agents in BRCA-related pancreatic cancers.
Yeah, and I think exciting to see both randomized studies with veliparib in combination with chemo, as well as a kind of a novel maintenance strategy with olaparib. So I think there's some certainly a lot of hope that this is a way forward. Is there a way to expand this population beyond germline BRCA?
Yeah, I mean, then there's potentially a BRCA-like signature that's been proposed. But I think that clearly needs to be validated in studies. But even in other tumor types, there's been a BRCA-like signature that we're hoping will be able to develop similar therapies, but certainly a work in progress.
Okay. Dr. O'Reilly described some other novel therapies moving forward, some of which may be glimmers of hope, such as targeting the stroma, the hyaluronidase. And others that there was hope, like the JAK inhibitor ruxolitinib, that hadn't panned out. What was your sense of other areas of interest?
Yeah, well, I think, lastly, certainly in hepatocellular cancer, we're seeing some promising preliminary data for immunotherapy drugs, and we await the results of randomized controlled trials, even a first-line trial comparing sorafenib versus anti-PD-1, anti-PD-L1 therapy, so that's going to be very anxiously awaited. In the second-line setting in sorafenib, either intolerant or progressive patients, we now have evidence that regorafenib conveys a survival benefit, so that's certainly a drug that may be up for regulatory approval in second-line therapy. And I think, the Great Debates format is really, we're bringing the authors that wrote these studies and presented the data in front of a live audience. And I think it's been an exceptionally good program this year. We've got world-class investigators that did the studies, reported the data, and are presenting not only existing data, but upcoming trials results, pitting our speakers against each other in a debate format to really do a point-counterpoint to get differing perspectives on the disease types. And certainly I think this is going to be in the future an ongoing very, very educational and provocative format, and we look forward to many such meetings in the future.
Wonderful. Well, thank you for your time and for sharing some of these insights. I think we heard about some real potential novel areas in gastric cancer, certainly some advances in neuroendocrine. We didn't touch on anal cancer, but certainly other areas that encourage you to explore some of the material from the meeting. It was a great discussions, certainly lively debates, and I think many of the participants came away with very good insights on how to better manage their GI malignancy patients. So Dr. Ilsen, thank you for organizing the meeting and thank you for your time.